So then when it comes to getting the disease, that's a good segue to carriers. So can we talk for a while about carriers and what the risk of vision loss is for various carriers, different genders, ages, etc.?
Well, the general figure that you will hear quoted is essentially if you're a man and you have one of the primary mutations, that your risk is about 50%. But of course, this will be influenced by other risk factors, like for example, if you smoke, because if you're a carrier and you smoke, then your risk is not going to be 50%, it's going to be nearly 95%, 100%, right? For female carriers, the risk is lower, it's 10%. But as Valeria mentioned, there are some case series where, for example, the 346 mutation, female carriers have an increased risk of losing vision, potentially because it's more pathogenic.
Yeah, the definition of carrier is someone who has the mutation and did not develop the disease yet, and possibly and hopefully will never develop the disease. So this has been one of the mysteries, and is still not completely solved, that we have been investigating in the last 10, 15 years. So the question is, why some people has the mutation and actually gets the disease and some other people is not. So one of the last findings that I believe are pretty relevant and in a sense are quite simple as an explanation is that the capability of develop a compensatory response to the mutation in carrier is higher than people that actually gets the disease. So this thing is possibly related to a genetic background, possibly related to the fact that some carriers are not smoking and drinking as the people getting affected. It's a very complicated interplay. One thing that I'm quite convinced and fits with the estrogen observation is that the compensation that carriers are able to carry out more successfully than the people having the mutation and actually getting the disease is based on mitochondrial biogenesis. If you have a system able to increase the number of your mitochondria in the presence of the mutation, you are more prone to maintain the mutation without getting the disease. If you are less able to do this business, then you're more prone to actually get the disease. Obviously, if you also smoke, drink, and do other things, despite your compensatory capability, probably at the end you will get the disease. So it's a very complicated interplay, but there are spontaneous compensatory mechanisms that make some people being the carrier, and this is a very important indication to use these strategies as a therapeutic strategies in the next future.
And so these are great directional avenues. What should somebody's eye care health plan be if they are a carrier? What should they do in terms of seeing someone?
Well, that's your...
Okay. There's a couple of reasons that I'm going to give this response. I think they should come in regularly and be examined. And one of the reasons is not for the carrier, but for humanity, for us, for research, for all of us, because we're going to be learning in the next decade, I think, more from carriers than for affected. And that's because we have now developed some tests that show changes in carriers too. So these changes are called subclinical signs. They're not obvious, they don't affect the vision, and that's by definition. If they affected the vision, we wouldn't call the person a carrier anymore. But being able to see the nerve fiber layer in certain areas swell and go away and certain color vision changes is, I think, going to tell us a lot about what's going on inside so that we learn about labors and hopefully do better next decade. The second reason is that there are going to be, probably in the near future, ways that we can modulate the disease that are going to be more important than carriers than even in the affected. Even the things we've talked about earlier today, don't smoke, don't drink, don't take these antibiotics. It might be important to communicate that. And even though I've seen many families come with some members of the family, when on the third visit they bring other members, by their questions it's clear they're learning from that interaction. So for those two reasons for sure, and maybe because in the near future we'll be actually treating carriers, we're not there yet, I encourage carriers.
And What about, are there other things that carriers can do to protect themselves that we didn't talk about earlier? Things like head trauma to consider?
Well, again, this issue of head trauma is based on anecdotal case reports, and there is no firm evidence that if you have a head trauma as a carrier that this will precipitate visual loss. And also partly what Alfredo mentioned is if you've experienced this catastrophic event of losing vision in both eyes, people tend to look for a reason why this has happened. So I think the pragmatic thing is, if you're a labor carrier, is to avoid from any contact sport that's going to expose you to potential risk factor more as a pragmatic position rather than there is hardcore evidence for this.
So if I understand you correctly, you don't recommend head trauma to carriers, but to everybody else you do.
I'm not sure what you do in your spare time, Alfredo.
Yeah, so no head trauma, no exaggerated exercise, physical exercise, no smoking and drinking, no being exposed to any kind of fumes. I mean, all the things that we have been talking about up to now.
Right. Is there anything someone can do if they're a carrier and they start being afraid something's happening with their vision and it might take them time to get to see you or a comparable doctor? Is there anything they can do?
I don't know. I have mixed feelings about the issue. On the one hand, we all have this instinct that if there's a good time to treat, you want to nip it in the bud, and earlier is better. On the other hand, I'm not convinced that really happens in labors. We've had too many occasions where a person has gone losing vision in one eye, put them on the medication that we really want to put them on before the second eye, and still watch the second eye go just as bad as the first eye, to make me think that it's just not really, at least it's not likely that we can nip this one in the bud. That said, I guess I still would like to have a person feel that they can reach me. There's at least two reasons for that. One is maybe that first statement I said is wrong. Maybe you can. It's worth a try sometimes to at least go over the antibiotics, all the issues that we've talked about. And secondly, I think it's really important that we study.
I think you're right. So far, there is no evidence that if the process has started, that there is a way of stopping it. And I think Valerie might know the latest, but certainly our colleagues in France where they were trying cyclosporine treatment to try and prevent the second eye, but as far as I know, it's not really been successful.
Yeah, well, this is a very long discussion. My impression is that once we understood in all details the pathogenic mechanisms, we will need probably a combination of different strategies, because on one side, just correcting the pathogenic mechanism, it takes time. So that's probably the reason why with the antioxidants, with idibenone or with EP743, you need to treat the patients for months, for years, in order actually to reach some sort of result at some point. So these are not drugs that are able to abort the disease, to stop it when it happens. On the other hand, instead of just trying to correct the pathogenic mechanism, there might be in the next future means to keep alive the cell, whatever pathogenic mechanism is ongoing. So we should avoid cells to be lost, to die. So if we combine a strategy where we keep the cells in place and we take time in order to correct the pathogenic mechanism, a combination of two things, that probably will be the successful strategy. That's my gut feeling.
One other thing I wanted to add to this point, that is that the carrier is still, like anyone else, apt to get mild eye disease. And while most people, when they get mild eye disease, say, it'll go away or it won't matter, naturally the person who comes from a family of labors is going to be very much more concerned. So to that point, there are a couple things that carriers can do to find out if this is the real thing and serious or not. And one of them is to check each eye individually. If you're looking together, your good eye will sort of mask any defect in the bad. So looking at things, covering one eye, covering the other eye is helpful. The first symptoms for labors, as everybody in this room I'm sure already knows, is either a dark spot in the middle of your vision, or maybe more subtly, the very earliest, is an inability to see bright color, particularly bright red. So that if you had a red scarf or a red hat and it looks red with one eye, but with the other eye it has become a pale orange, that would be the real thing. But if you've got floaters, and half the people in the world will sooner or later get floaters, a little bit of dust that's floating about in your eyes, then you need not panic.